Your doctor has recommended a routine test, a screening, something to catch a problem early, just to be safe, and you are thinking about saying yes because that is what you have always done, because early detection sounds like the responsible choice, because nobody has ever told you there might be a reason to pause and ask a question first. I want to be the person who tells you that, not to create fear of medical care, not to suggest you avoid your physician, but because after 70, the mathematical relationship between screening tests and health outcomes changes in a way that most appointments never address, and you deserve to know about it before you agree to the next routine procedure. If this channel has ever given you something worth knowing, hit that subscribe button right now, leave a like, and drop a comment below, because that is what keeps this kind of conversation reaching the people who genuinely need it. I'm Dr. Mercer, and this channel exists to bring you the latest evidence-based research on senior health, simplified and designed for adults over 60. Stay with me through this entire video, because by the end you will have 4 specific questions that can fundamentally change every medical conversation you have from this point forward, a clear understanding of which 5 routine screenings carry the highest risk-benefit shift after 70, and the language to discuss your own situation with your physician from a fully informed position. Let's begin with the concept that makes this entire conversation matter. It is called the Cascade Effect, and once you understand it you will see it operating in the medical system every time a routine screening test finds something, a spot on a scan, a slightly elevated marker, a shadow on an image. The physician, following standard protocol, must investigate. More tests are ordered, perhaps a biopsy. The biopsy identifies something that requires a decision. Now you are discussing surgery, chemotherapy, or radiation. Each of those steps carries its own procedural risks: infection, bleeding, anesthesia complications, hospital-acquired pneumonia, falls during recovery, delirium, and in some older adults, a degree of cognitive decline that never fully reverses. Here is what the research consistently and soberly confirms: after 70, a meaningful proportion of the conditions these screenings detect would never have caused a symptom in that person's remaining lifetime. They would have stayed dormant. The individual would have lived their full life and never known the finding was there. The cascade that began with a routine test would have done more harm than the condition itself ever would. A landmark study published in JAMA Internal Medicine examining overdiagnosis rates in older adults found that a substantial proportion of cancer diagnoses made through routine screening in patients over 75 were clinically inconsequential, meaning the detected condition had no realistic probability of causing death or significant symptoms before the patient would have died of other causes, yet the treatment process for those diagnoses produced measurable harm. That is not a fringe finding, it is the reason multiple major clinical guidelines have been progressively adjusting their age-specific screening recommendations over the past 2 decades, often in ways that have not reached the standard appointment. Let me walk you through the 5 specific screenings where the risk-benefit calculation has shifted most significantly after 70, why each one creates the cascade, and what the evidence supports instead. The first screening is routine colonoscopy after the age of 75 in adults who have been previously screened and found to be clear. The United States Preventive Services Task Force explicitly recommends against routine colonoscopy screening for adults over 75 who have had regular prior screenings with normal results, and yet millions of seniors over 75 continue to receive them annually. The procedure itself carries a perforation risk that, while small in absolute terms, becomes clinically significant when the individual is in their late 70s or 80s. A bowel perforation in a 78-year-old frequently requires emergency surgery, intensive care admission, and carries a mortality rate of between 25 and 30%. The bowel preparation itself causes severe dehydration in older adults, which in those with compromised kidney or cardiac function can precipitate a serious clinical event even before the procedure begins. The counterpoint is this: if you have been screened regularly and your previous colonoscopies were clean, the probability of developing a life-threatening colorectal cancer in your remaining years is genuinely low. The risk of the procedure and its potential cascade now exceeds the benefit of early detection for most people in this situation. I had a patient I will call Gerard. He was 77. Had 3 clean colonoscopies, and was referred for another as part of a routine scheduling protocol. When we sat down to review his specific situation, the recommendation for continued screening was based on scheduling rather than on his individual risk profile. After a discussion of the risk-benefit calculation at his age and with his prior clean results, he and his physician together agreed to defer further routine screening. 2 years later he remained symptom-free and had avoided a procedure that carried meaningful procedural risk. The second screening is routine PSA testing for prostate cancer in men over 70 and mammography in women over 75. For men over 70, the PSA test has a false positive rate approaching 80%. That means 8 out of 10 men who receive an elevated PSA result do not have a clinically significant cancer, but the test result initiates a process. Biopsies are performed. Prostate biopsies carry an infection risk of approximately 5%, cause urinary complications, and generate anxiety that can persist for months. And for the cancers that are actually found, many are slow-growing tumors that would never have caused symptoms in that patient's lifetime. Treating them with surgery or radiation produces incontinence, sexual dysfunction, and a dramatic reduction in quality of life, for a cancer that was never going to hurt the patient. For women over 75, the United States Preventive Services Task Force found insufficient evidence to recommend routine mammography, specifically because the lead time of cancer detection relative to the remaining life expectancy shifts the balance. Cancers detected may be slow-growing and unlikely to affect life expectancy, while the biopsy and treatment cascade produces measurable harm. The question that should be asked in every appointment where these tests are proposed is, if this test finds something, what would the treatment look like for someone my age and my current health status, and is that treatment likely to extend my life or significantly reduce my quality of it? The third screening is routine cardiac stress testing in patients with no cardiac symptoms. Stress tests are ordered routinely for older adults, particularly before elective surgical procedures. But a stress test in a patient who experiences no chest discomfort, no unusual shortness of breath, no dizziness during normal activity, is searching for a problem that may not exist. False positive rates in asymptomatic patients over 70 exceed 30%. A false positive result initiates cardiac catheterization, an invasive procedure in which a catheter is threaded through the arterial system to the heart. Complications include arterial injury, stroke, heart attack during the procedure, and kidney damage from contrast dye. These risks are meaningfully higher in older patients. If you can walk at a reasonable pace, climb stairs, and perform your normal daily activities without cardiac symptoms, your daily life is already demonstrating what the treadmill test is designed to measure. The key question before agreeing to a stress test is, am I currently experiencing symptoms that suggest a cardiac problem? If the answer is genuinely no, ask your physician specifically why this test is being recommended and what the plan is if something is found. The fourth screening is bone density scanning, or DEXA scanning, in patients over 75. For women in their 60s, bone density assessment can provide meaningful guidance for prevention, but for patients over 75, the scans almost universally demonstrate bone loss, because progressive bone loss is a normal and expected feature of aging. At that stage, the problem is what routinely follows the diagnosis. Bisphosphonate medications are prescribed. These medications have been linked to esophageal damage, jaw osteonecrosis, and a paradoxical risk of atypical femoral fractures, where the thigh bone fractures in an unusual location precisely because normal bone remodeling has been suppressed. For many patients over 75, the side effect profile of bisphosphonate therapy represents a greater risk than the fractures the medication is designed to prevent, and the single most evidence-supported intervention for fracture prevention in older adults is not pharmacological, it is exercise, specifically balance training and strength work, combined with home modification to eliminate trip hazards, and ensuring adequate vitamin D. These interventions address the fall itself, which is the actual mechanism of the fracture, rather than addressing only the bone density component. The fifth and most consequential screening is carotid artery ultrasound in patients with no neurological symptoms. A carotid ultrasound identifies blockages in the arteries that supply blood to the brain. In a patient who has experienced transient neurological symptoms, visual disturbances, sudden weakness, or speech difficulties, this test is clinically appropriate and important, but in a patient with no such symptoms, the cascade it initiates is among the most dangerous in medicine. A blockage is identified, a vascular surgeon is consulted. Carotid endarterectomy, surgery to remove the plaque, is recommended. In patients over 75, this surgery carries a stroke risk of 3 to 5%. The surgery intended to prevent a stroke can cause the stroke it is trying to prevent. The landmark ACST trial, the asymptomatic carotid surgery trial, found that in asymptomatic patients, The benefit of carotid surgery was negligible in adults over 75, the surgical risks essentially cancelled out any potential benefit. Before I give you the action steps, I need to say something with absolute clarity. Nothing in this video is a reason to refuse medical care, to cancel a scheduled procedure without discussion, or to decline a test your physician has recommended based on specific symptoms you are currently experiencing. Every screening discussed in this video is being addressed in the context of routine, asymptomatic screening ordered primarily because of age rather than in response to a complaint. Symptoms change everything: unexplained weight loss, bleeding, new or changing pain, neurological changes, vision disturbances. Any new symptom that has not been explained warrants prompt medical evaluation regardless of your age. The message here is not that screening is harmful, it is that routine screening in the absence of symptoms, after a certain age, must be evaluated individually rather than ordered automatically. Now, what does a constructive alternative framework look like? The evidence consistently supports functional health assessment over structural imaging for most purposes after 70. Can you walk 2 flights of stairs without cardiac symptoms? Can you rise from a chair without assistance? Is your balance adequate for daily movement? How is your cognition in practice? These functional assessments reflect how your body is actually working far more accurately than many structural screenings applied in the absence of symptoms. I want to tell you about a patient I will call Dorothy. She was 78, had no specific health complaints, and had been referred for a carotid ultrasound as part of a general cardiovascular risk assessment. When we reviewed her situation, she had no neurological symptoms of any kind, no family history of sudden stroke at young ages, and no risk factors that elevated her above the average for her age group. We had a direct conversation about what the test would measure, what a finding would initiate, and what the ACST trial data showed about surgical outcomes in her age group. She and her physician decided together to focus on optimal medical management of blood pressure and cholesterol rather than structural screening that carried a meaningful procedural cascade risk. A year later she was well, active, and had avoided an invasive pathway that may have done more harm than her risk profile warranted. Here is exactly what to do. Step 1. Before your next scheduled screening, write down whether it is being ordered in response to a specific symptom you have reported, or as a routine age-based protocol. That distinction matters to everything that follows. Step 2. At your appointment, ask your physician the 4 questions that should precede any screening after 70. What happens if I choose not to have this test? If the test finds something, what would the complete treatment pathway look like for someone my age and health status? What are the risks of the follow-up procedures that a positive result would initiate? And is watchful waiting a clinically reasonable alternative for my specific situation? Step 3. Ask your physician specifically whether the guideline recommending this screening was developed using evidence that included patients in your age group, or whether it was extrapolated from younger populations. Many screening guidelines were built from studies of middle-aged adults. Step 4. Request that any screening recommendation be individualized to your specific health history and life expectancy rather than applied automatically based on a scheduling interval. Step 5. Ask your physician what the current evidence-based alternatives are for addressing the concern the screening is designed to address, particularly whether lifestyle, medication optimization, or symptom monitoring might provide equivalent protection without the procedural cascade risk. One final clarification that matters for the credibility of everything I have said: all 5 screenings discussed in this video have clear clinical applications and remain appropriate in specific circumstances. Colonoscopy is appropriate for investigating symptoms, for individuals with a history of polyps, or for adults with a family history that elevates their personal risk. PSA testing and mammography are appropriate when requested by an informed patient who understands the trade-offs and chooses to proceed. Stress testing is appropriate when cardiac symptoms are present. Bone density scanning is appropriate for guiding treatment decisions in younger postmenopausal women and for monitoring response to treatment, and carotid ultrasound is appropriate for patients who have had neurological symptoms. The concern expressed in this video is specifically about applying these tests routinely to patients over 70 who have no relevant symptoms and whose individual risk profile has not been evaluated independently of the scheduling protocol. That is the context in which the cascade effect causes preventable harm. After 70, the medical system should be measuring how well you are living, not just searching for ways your body could be failing. The 4 questions in this video are your tools for ensuring that every screening you agree to has been honestly evaluated for your specific situation rather than ordered automatically. If this video gave you something useful, hit the like button right now. Leave a comment telling me whether you have ever experienced the cascade effect from a routine screening and how it affected you, and share this with someone you care about who is over 70 and approaching a routine medical test without knowing they have the right to ask these questions first. Subscribe if you have not already, and I will see you in the next one. Take good care of yourselves.